Well, thank you again. It's a pleasure to speak here. I think I've been given the toughest topic. Kobe, thanks very much for the whole meeting here. For the good news is I originally wanted to be a medical oncologist, not a surgeon, so I got to dust off some beliefs. So here we go. So I think most of us are believers in active surveillance. I certainly am in appropriate patients. And I think we all embrace active surveillance largely in prostate cancer because we know that in many cases it's a tumor with a long natural history and it poses minimal threat to life. We have reasonably good ways to predict biology, particularly the GLEASON score, although there's much maligned about the GLEASON score. I would actually argue that it's largely served us quite well over the last 40 to 50 years. And there's no doubt, as we just heard with some of the new profiling and molecular omic revolution, we'll have more and better tests as time goes. I think the other important concept around active surveillance is, as I always tell my patients, the prostate lies in a very delicate part of the body, and messing with it can affect sexual, urinary, and bowel function. So the morbidity associated with treatment also has to be taken to the equation. And I believe as well that, and this is one of my slight concerns in kidney cancer, is that at least in prostate we have effective salvage therapy. So even if a patient did squeeze through, the vast majority at least can be managed with hormone therapy and not die imminently, and perhaps and largely live decades or more. So I've pulled out a few little other types of tumors here and gone through some of the literature. I'm going to talk about ductal carcinoma in situ of the breast, papillary thyroid cancer, myeloproliferative disorders, and desmoids, and see how these are treated and how maybe we can learn from them or vice versa. So here's ductal carcinoma of the DCIS, or ductal carcinoma in situ of the breast, which is a carcinoma of the milk ducts. There's a variety of different pathological subtypes, and these are typically found on mammographic screening. And I think it's interesting looking at PSA screening and how the winds of change are coming out against PSA screening, where there's actually very little debate, or at least serious debate at the governmental levels about stopping screening for breast cancer. But the fact is, as the imaging of the breast gets more and more sensitive, more and more of these anomalies are being picked up. It's now estimated that about 40% of all cancers detected by mammography are actually non-invasive ductal carcinoma in situ. And the reason why that's important is because the natural history of this condition is quite minimal. So to give you a little bit of sort of tidbits around DCIS and trying to relate it back to prostate cancer, one of the concerns around DCIS is underestimation of disease. We just heard about MRI, we just heard about molecular profiling, but basically about 20% of cases that go to the operating room for a lumpectomy with DCIS have unrecognized microinvasion. So that would be similar to our upgrading phenomena in prostate cancer. And also sometimes the discovering of secondary tumors, for example, in the anterior zone. That's less likely to happen, again, because of all the imaging that's happened. On the treatment side, it's actually a little bit sobering. Ductal carcinoma in situ is largely treated as an invasive malignant breast cancer. Patients get lumpectomies, not infrequently a mastectomy, depending on the size of the breast and the size of the lesion, and they are consolidated, as we just heard from one of the audience, with radiotherapy. If we look at the recurrence rate of this condition at 10 years, it's 25%. That's the rate of getting a recurrent ductal carcinoma in situ. And it's very similar to prostate cancer. You can see higher risk patients are those who are younger, those who have larger tumors, those who have higher grade, albeit we don't subtype grade in prostate cancer for surveillance, but I guess if we were gonna do surveillance in 3+4, that would be an example similar to breast cancer. And then there's the comedo type of pathology, which are particularly nasty. Interestingly, there's been an attempt at using medical therapy as well, not dissimilar to prostate cancer in surveillance. This is from a Cochrane review published 2 years ago. Looking at tamoxifen in this setting of DCIS, and you can see here that it reduces the risk of recurrence by 25% in the ipsilateral breast and 50% in the contralateral breast. There is no impact on death. And however, similar to some of our medical therapies, there can be adverse effects, fatigue, bone health, vaginal dryness, risk of endometrial cancer, all associated with tamoxifen. So I guess the analogy in prostate cancer would be the use of 5-alpha reductase inhibitors, and these are the results published in Lancet 2 years ago, looking at the use of 5-alpha reductase inhibitor dutasteride for patients on active surveillance, and we were able to show in that particular paper a 40% reduction in the risk of progression on active surveillance with the use of 5-alpha reductase inhibitors. I think another interesting aspect looking in the literature is that there's great interest in the biology of breast cancer as there is in prostate cancer, and there's an interest in metabolism as a means to alter outcome, not income. Maybe that's a Freudian slip. I was able to find 3 large-scale trials of metformin. That's funny. Of metformin, including one in ductal carcinoma in situ, and I'll just make a little plea here for David Margell, one of my fellows. This is some of the seminal work he did when he did his PhD with me, looking at the use of metformin and preventing prostate cancer deaths among patients in Ontario. This was a 29,000 patient cohort, and we looked at the use among diabetic men, and those on metformin seemed to have about a 36% lower chance of death from prostate cancer, and this was unique to metformin, not seen in other types of oral or even insulin anti-diabetic type therapy. And this has led, again, with in part to David's seminal work, to our knowledge, the first large-scale metformin randomized trial, which is now underway in Canada, where we're taking patients who have very low-risk prostate cancer, randomizing them to placebo or metformin with a rebiopsy at 18 to 36 months, and this trial is currently accruing patients. Of course, quality of life in breast cancer, I want to be politically correct here. I am going to say that having a scar on your breast and probably having it radiated is not the same as having your prostate out, but I recognize I could have darts thrown at me. But I don't think we should also underestimate the psychological impact of losing a breast or even having treatment for breast cancer for a woman. It has a lot to do with their femininity and sense of womanhood and impact on sexuality. Not that totally dissimilar to prostate cancer, albeit it's more a mechanical issue in terms of prostate cancer. But treatment for breast cancer also has other effects. Some patients have residual mastodynia or pain in the breast, and there is evidence, although now with modern techniques it's decreasing, of increased pulmonary and or cardiac toxicity from left breast radiation, in particular with the cardiac. Death rates from DCIS are, in my view, very analogous to Gleason 6 prostate cancer. They're virtually unheard of, and it's about, based on my calculations, about 1/20th of the people who get it. So it's about 1 to 2% overall. And again, very similar to DCIS, its major issues is a risk of underdiagnosis. And interestingly, the talk of surveillance has been one opinion piece published this year, talking about perhaps embarking on active surveillance for these lesions, but that's it. So this is a very, in my view, a fertile area for research. What about thyroid cancers? This is another interesting group of cancers, not unlike prostate, extremely common as we age. You can see that it's now estimated that about 1 in 20 adults have a palpable thyroid nodule, and on ultrasound, about half of us would have a sonographic nodule, of which about 10 to 20% are malignant. And of course, like prostate cancer, you get thyroid cancer as you age. It's about 1 of 3 people have small thyroid cancers if you look at people who die from other causes. Interestingly, low-risk thyroid cancers are rarely associated with death. And this showing the incidence of thyroid cancers going through the roof virtually in every country in the world, largely due to imaging. And in particular, papillary thyroid cancer is interesting. The 20-year mortality from this disease is 1%. It's even better than prostate, even low-grade prostate. And yet the guidelines still maintain that thyroidectomy is the treatment of choice, and there's even a debate about whether to do a neck dissection in patients. Fortunately, the Japanese have embarked active surveillance for low-risk thyroid cancer. This is, I'll show you the results of 2 major studies. One published this last year by Ito and the other by Sugatani, and you could see with reasonably large numbers of patients, the disease-specific mortality to date is basically zero, and a small proportion, 1 to 2%, developing lymph node metastases. And you can see here follow-up is in the 5-year range. So this is a start in thyroid cancer, and there's a small group at Memorial Sloan Kettering, that's PACE, this group, and I know a cohort has now been opened up. So patients here are basically monitored, they're rebiopsied of their nodules, and this is becoming perhaps a peek into the future of where things will move. The major driver here, again, is mostly around cost and morbidity. It's not around life savings, and I think this particular graph shows it well when you're looking at thyroid surgery versus surveillance, need for lifelong thyroid replacement, 0 versus everyone with a total thyroidectomy, and I guess half who have a partial thyroidectomy. The costs are quite large, but what's interesting about this analysis is they don't actually cost the follow-up. Well, I can tell you that there has been some cost analyses in active surveillance of prostate cancer, and I can tell you from a physician reimbursement point of view, you actually make more money doing active surveillance than operating on a patient, at least in Canada, and that's assuming the patient sticks with you and sticks to the treatment plan. In terms of complications, you can see obviously they're rare, but I think the one that takes me here is there's still about a 1 in 1,000 mortality rate from a thyroidectomy, and that is quite high if you think about a disease that has a 1% mortality rate at 20 years. What a shame to lose a patient, even if it's 1 in 1,000, to a disease that may kill you that's unlikely to kill you 20 years later. I'll talk about desmoid tumors. Now, these are very different, unlike DCIS and thyroid cancer. These are tumors that I picked because they have a very variable behavior, some very indolent and some actually quite aggressive. This is, for those of you who don't know, is basically a benign condition called aggressive fibromatosis, but it is a monoclonal fibroblastic proliferation, but they can be locally invasive, they don't metastasize, and they tend to recur post-op. I'll just show you one example. This is a large pelvic desmoid. I'm sure many of you in the room have been involved with these resections. They often involve colorectal surgeons, urologists, gynecologists, vascular surgeons. They can be quite difficult in the clinical setting, but they can exist anywhere, of course, in the body. And the issue here is really the haphazard and less well-defined natural history of these tumors. And the main reason people for these tumors do not treat them aggressively surgically in most cases is not because of the concern about disease, but mostly of the concern of morbidity of treatment. These often involve double ostomies, major bone resections, and watchful waiting is usually the preferred choice for the larger lesions. The small ones, if you can get them out with a negative margin, that's the way to go, but it's almost like there's a threshold point at which you're almost best off leaving it and let it do its thing because of the quality of life. So it's somewhat related to prostate in the sense that we're concerned of quality of life impairment, but certainly not on this level. And lastly, I'll just finish off about lymphoproliferative disorders. So these are not solid tumors, of course. I'll talk about low-grade lymphomas and myeloproliferative neoplasms. And I think the interesting thing looking at these neoplasms is their natural histories are unnatural but generally long. They're a little different than prostate. So you can live 20 years with CML, or you can live 5 years, but every one of these patients lives with this cloud that it may progress and transform into an acute leukemia. So this is a little different where you know you're going to be good if you play the odds, but it's not an insignificant proportion, and quite suddenly can have the disease basically go off the rails. I think what's impressed me the most about these tumors is that the basic science advances in these tumors has been fantastic over the last 10 years, and the biologic understanding has really revolutionized these. We all know about Gleevec and its role in CML. Rituximab, which is an antibody to CD20, has had remarkable results. I'll show some of those. And not only on the therapeutic side, but on the prognostic side. We were talking earlier about some of the new genetic markers like Oncotype DX and the genomic markers such as the Myriad test. I think those types of tests are now being applied in the myeloproliferative space and low-grade lymphoma space to good use. So here's quite an interesting article I recently found looking at a single-agent rituximab in patients with low-grade follicular lymphoma. And this is the old data. This was chlorambucil, oral chemotherapy. And you can see here that the basically chlorambucil or observation had basically the same impact on outcomes. In this case, it was a need for sort of changing your treatment decision. But look what's happened since rituximab has come on. So better science, better understanding of the biology, and development of new drugs that keep things at bay, and therefore altering treatment paradigm. And then also subcategorization. I was talking about markers. Here's a CLL markers, and you can see how now using a variety of different either genetic anomalies or looking at some chromosomal anomalies. Otherwise, you can subcategorize patients into very poor risk and reasonably good risk depending on their profiles. And these, remember, otherwise look the same under the microscope, perhaps like some of the Gleason 6 tumors we heard about just earlier. So in this case, I think there's been an advance in the science that's led to better outcomes. So lessons learned in total, tough, thanks Kobe for giving me this topic, but I would say that I think in the myeloproliferative space, I think it's a bit of a peek into the future of where we'll be, where a better understanding of the molecular biology will make active surveillance safer and perhaps allow us to either understand who will do best with, for example, dutasteride, or perhaps develop novel agents, maybe metformin. So I will conclude this all by saying that active surveillance is a novel paradigm that has been led by urology, and especially the moderator of this session. And I'm going to finish this off by trying to paraphrase John Kennedy: ask not what we can learn about AS from other oncologists, but ask what they can learn from us in order to manage selected cancers. Thank you very much.